Hello again in the ESO TV studio. We've swapped guests. We still have the same convener, so me, myself, Annemijn, and Louise from Belgium, and we are delighted to have two of the PIs from the last large clinical trial session with us here. Very honored to have Michael Mazighi. I did pronounce it right, yes?
Great, it was great.
Yes, okay. And Diane Aguirre de Souza from Portugal, and you're from Paris in France. Yeah, very welcome. Yeah, so we would like to talk with you about the trials and, of course, about your wonderful results. But before we come to that, Diane, I want to congratulate you with your prize. Very well deserved.
Thank you very much.
Very proud of you.
Thank you very much. It really reflects the support of many people.
Yes, and can you enlighten us a little bit about well, what you actually just told us in the large clinical trial sessions? Maybe give a short summary.
Yes, thank you, Annemijn. Indeed, so the EXCO CVT study was an international study that included a cluster randomized trial and also a parallel prospective observational study. So overall, the study included more than 1,500 participants, about more than 440 in the cluster randomized arm, and then more than 800 in the observational study. The inclusion period was 9 years, and then the follow-up was 24 months. This was a study which aim was to compare after cerebral venous thrombosis without an indication for definite anticoagulation because of a very high risk of recurrence. In this group of patients for which there is uncertainty on what should be the duration of anticoagulation, very low quality of evidence in the guideline, in the last ESO guideline on cerebral venous thrombosis. The aim was to compare a short-term policy defined as 3 to 6 months and a long-term policy defined as 12 months. Indeed, we compared the venous thrombotic events recurrence and also mortality and bleeding events defined according to the ISTH criteria. The final results show that in patients that received short-term anticoagulation defined as 3 to 6 months had the same rates, not significant different rates of thrombotic events compared with a long-term policy. Although there was indeed in the cluster randomized trial a numerically higher rate of thrombotic events. So the rate in this group of patients was in the short-term policy was 4.4%, and then in the long-term policy 7%. So indeed there's some numerical difference, but there's no significant difference overall. Also in the subgroup analysis, we could see that there was interaction for sex with a higher rate of thrombosis, venous thrombotic events in patients on the short-term policy, male patients on the short-term policy, with a rate of 20%, which was substantially higher than in male patients on long-term anticoagulation. However, this is only, although it was predefined, there is only a subgroup analysis, and so it's hypothesis generating, and we do need further evidence in the future, but we will look into this subgroup as well in more detail.
Very interesting, and well, that also brings me straight into clinical practice. So in Lisbon, what do you do, and how do you how do you bring these results forward to clinical practice, or what are your advices?
Yes, so the results support that there's no benefit in extending anticoagulation beyond the 6 months, routinely at least. Of course, this can be considered in selected cases and individualized based decision making. But overall, since there's no significant difference in the recurrent events, and we know that although the bleeding events were not different, there were higher rates of mortality, even significant difference in the observational study in patients on the long-term policy. That also is a sign towards higher risk with long-term anticoagulation. And so what we do now is indeed to do the 6 months policy in this group of patients, unless there's any specific reason or personal preference of the patient towards other decisions.
That's a very clear message. And Louise, what do you do in Belgium at your hospital?
Right now in our hospital, we do a 3-month anticoagulation regimen for these patients, and then we follow them up at the 90 days follow-up consultation. And most often we do a repeat scan to see how things are going. But I must admit that it really depends on the patient, on the scan as well. About our decision thereafter. So sometimes we continue for a little while if we feel that, for example, there are still risk factors being present, but sometimes we also stop. So I think, that these findings will also maybe challenge us to look at it and maybe change our policies. I don't know how it is in your center, Michael.
Yeah, we usually go for 6 months, sometimes 12 months, but yes, usually it really depends on the physician. So I think it's really important to have such data, to uniformize clinical practice and having the same way of following patients and treating patients. So
Indeed, that's an important point. In fact, in the trial, for the short-term policy, since it was the clinical practice, there was some variation. It was allowed between 3 and 6 months, but indeed almost all centers, because this is a cluster randomized decision, almost all centers opted for the 6 months policy, and the mean duration of anticoagulation in both studies was really around 6 months for the short term.
Okay. Another question for you, Diana. We know that the disease is more rare than, for example, ischemic stroke. This also reflects, I think, that there are often studies that require lots of centers, lots of physicians involved. Are you motivated for a new trial or a new ID, and do you have already IDs for this?
Yes, so indeed this was really a global effort. The study included 21 countries, 43 centers, over a period of inclusion of 9 years, and then a follow-up of 24 months. So indeed studying rare diseases, because cerebral venous thrombosis has a frequency in Western countries around 13 cases per million per year, so it fits the definition of a rare disease. It brings a lot of challenges, but still it is very important that we have high quality evidence, as Michael was mentioning, also for these patients. This trial population had a mean age of 40 years, 75% women. So it is really important that we can provide reassurance in terms of the decisions we make.
Mm-hmm. Yeah, definitely. I totally agree.
Yeah, and when we were actually discussing it just beforehand, now you also made a very interesting comment about doing follow-up imaging, because I think there's a lot of variability there too, and that you said, well, we do the follow-up imaging for a baseline. Can you enlighten us on that?
Yes, so there are. I'm aware that there are some centers, or at least some colleagues, that consider also the recanalization rates for the decision concerning duration of anticoagulation. Indeed, that's an interesting hypothesis, although we don't have evidence to support that doing longer-term anticoagulation treatments will modify recanalization rates after some time, or even that is an outcome that will very much affect the follow-up of these patients. However, there is an association from systematic review and meta-analysis data between recanalization and recurrence rates of CVT. So there may be a higher risk of recurrent CVT in patients that have persistent occlusion. Still, we don't have an evidence for that, so we always do follow-up imaging around 3 to 6 months, but the goal is especially to have a baseline follow-up imaging so that if there are symptoms of possible recurrent CVT, we may be able to compare and to understand if there are new thrombi, if there is indeed new thrombosis, and that is quite helpful in that regard. So yes, we do it, and another topic for future studies is probably this question of recanalization and duration of anticoagulation.
Yeah, very practical also, and then I think it's time to move to you, Michael, and I would like to ask you the same question to give us a brief recap on the GREEN trial you presented earlier this morning.
So sure, with pleasure. So GREEN was a phase 2-3 trial. It came after 2 other trials. There was a first trial in 2024, the Actimis trial, showing a potential benefit of this drug. So the glenzocimab is a an antibody which targets a glycoprotein in platelets, GP6. And the inhibition of this GP6 is not associated with an increased risk of bleeding. So it looked like a very promising drug. And in fact, the first study, the Actimis study, showed a tremendous reduction of mortality. And this mortality was mainly driven by an excess risk of bleeding in patients that were all treated with alteplase within 4 hours and 30 minutes. And when we looked at the subgroups of the Actimis study, it appeared that the patients that were treated with mechanical thrombectomy seemed to benefit most from this therapy. So that was in 2024, but earlier this year we had the ActiSafe study with a more broader population, anterior and posterior circulation stroke, and milder strokes. The median NIH was 9, but this study, the ActiSafe study, didn't reproduce the results of the Actimis. So with the green study, we thought that it was a more focused population, only EVT treated patients. They were selected for clinical radiological mismatch. So supposedly a population that was more prone to benefit from therapy. But still we have a pre-planned interim analysis, and the study was stopped for futility. And there was a trend for worse outcomes in the glenzocimab group.
Yes, very interesting results, and it looked so promising. And maybe you want to ask a question about that?
Yes, we often see that it's a challenge to translate findings from phase 2A to B studies to then the phase 3 studies. And I was wondering, in this particular field, what are your thoughts on that? And maybe also more in general, how can we tackle these challenges? How can we improve maybe design, or how can we translate these findings to then phase 3 and then real world practice?
So, you know, when we write articles regarding phase 2 trials, we used to conclude the article saying that we need to reproduce the data in larger studies. It's like, you know, something automatic, and I have to say that. But this is very interesting because Actimis study and ActiSave or Green, they show that. You need really to reproduce findings in large sample size, because the problem with phase 2 studies, the sample size are limited. So with few patients, you can go from a good result or a negative result. So that's the need for larger sample size. And probably one way to address it is, going for a more adaptive design with Bayesian design, where you can modulate during the trial the sample size. Could be an option.
Yeah, great idea. I also had a question in your trial about the follow-up or post-EVT antiplatelet or anticoagulant regimen for patients. How was it organized, or did you have protocol specifications on that?
So usually patients that had TPA on board, which was the case in 74 to almost 80% of the patients, we don't give any antiplatelet agent for 24 hours. So for patients that don't receive IVT, you may consider antiplatelet option. But for this trial, as it was already an antiplatelet agent, no antithrombotic, no additional antithrombotic therapy was given during the protocol. It was a double-blind protocol, so we didn't know if the patient was receiving the drug or the placebo.
Okay. Following your presentation, there was actually also some work presented on a antiplatelet inhibitor giving during or immediately post-EVT, tirofiban. What are your comments on the results presented in these, I think, 3 trials?
Sure. So there is a lot of research on tirofiban actually. So, we to make a parallel with intra-arterial fibrinolysis after mechanical thrombectomy, we have these studies with choice study showing a proof of concept that you open up the vessels with mechanical thrombectomy, but still the microcirculation, although we don't have key imaging to identify the microcirculation obstruction, there is a need to additional lytics or antithrombotic drugs, despite recanalization with EVT. So I think there is a need for distal occlusion or microcirculation. And then you have, let's say, different candidates. Lytics and antiplatelets, and tyrofibin is one of them. So I think that's an option that needs to be tested, and it's already tested, and we need to test it also in different populations, because we have seen that we have many data coming from China or Asia. We know that in Europe we don't have exactly the same patients. We all know that in China or in Asia there's a higher prevalence of atherosclerosis, which is not the case for European people. So we need to reproduce this data with different populations to see if we found the same results. Yeah.
And can I ask, do you have or used tirofiban already in Paris?
Well, in my center, we do use another antiplatelet therapy, which is Cangrelor.
Ah, yes.
Cangrelor is an inhibitor of Y12 receptors. The very interesting thing with Cangrelor is it's a drug with a very short half-life. So when you stop it, 1 hour afterwards, you have a platelet function which is normal. So it's really an easy drug to I would say to manipulate if you need emergent surgery or if you have an adverse event like an intracranial bleeding. So we are more used to, yes, with Cangrelor rather than tirofiban.
And can I ask you the same question? How is it in Portugal?
Yes, so concerning GP2B3A inhibitors, we mostly use eptifibatide in our country. Actually, tirofiban is not available at the moment for this purpose, but maybe this new evidence coming from several studies is a call out to the authorities to make it available, and we look forward also to see the sub-analysis and the future studies reproducing these results.
Absolutely. And what about Belgium, Louise?
Yeah, I think we are not super experienced giving these drugs during or immediately post EVT. The only thing that we sometimes do is when we have to place a stent in case of tandem lesions, then we, of course, want to give, for example, aspirin already during the EVT procedure, and also sometimes feel that we need to give an extra dose of tirofiban, and that's something that we do on a regular basis when we stent during a thrombectomy. But besides that, I think we were really waiting for more evidence, and findings from today will definitely maybe already guide us towards the direction, but more trials are obviously also needed.
We, as your Dutch neighbors, do the same. But yeah, no, it was a lot to digest. So many adjunct therapy trials. There's definitely a field that deserves more attention. Very, very interesting. Do you have some final words on where you're going next after the green trial?
So yes, currently we are testing and evaluating Cangrelor as an adjunct therapy to mechanical thrombectomy. So yeah, we hope we will have some new data to bring out to the community with this drug.
Yes,
so we'll see.
Yeah, I already heard the PI from the CASES trial mention the same word, so that is also a therapy to keep in mind, absolutely. Okay, well, over to you, Louise.
Yeah, many reasons to come to ESOC also the coming years with all these great ideas that you have. I think it's time maybe to wrap up this session. I want to thank Diana, and I also want to thank Michael. They did some great summaries on their work. Diana has put great effort in giving us more evidence on the long-term anticoagulation in CVT, cerebral venous thrombosis patients. And Michael has elaborated on the results of the GREEN trial. Thank you again very much. Congratulations. Have a very safe trip home. And I think with the wrap-up of this session, it's also maybe good to have a wrap-up of the entire ESOC conference. I think we all had a great time and are already looking forward to next year. And now it's time for a great summary video of the conference.